All right. Good evening, everybody. Thank you for joining us for tonight's lecture. Tonight, we are going to be talking about abdominal and pelvic trauma in sports. My name is Alex Tomesch, and I will be your moderator tonight. And I will introduce our speaker here in a second. Just to highlight, next week's lecture will be on high-risk overuse injuries. It will be moderated by Laura Goldberg, and our speaker will be Neru Gianthi. So that's next Wednesday again at 8:30 Eastern time. Just to go over the goals quickly, the goals of this lecture series is to provide an adjunct to home programs educational content and to provide fellows with direct access to educational experiences with other AMSSM members and at times invited guest experts. And finally, to help assist in CAQ exam preparation. Basic ground rules, please mute your device's microphone and turn off your video. You can submit any questions that you have through the chat, and then I will go through the questions and ask them at the end during the Q&A session. We would really appreciate if you guys would take the time to complete the evaluation at the end. There are a couple ways to that. You can either go online and go to this hyperlink by going to amssm.org, education, and then the fellow online lecture series, or there should be a QR code on the next page here. All right, and without further ado, our speaker tonight is Dr. Ross Mathiasen. He did his primary specialty residency in emergency medicine at the University of Iowa and did a sports medicine fellowship at the University of Iowa as well. He currently works at the University of Nebraska Medical Center, where he works in the emergency department as an associate professor. He also is the assistant program director for our primary care sports fellowship program, and he is the head team physician at the University of Nebraska in Lincoln, helping take care of the Husker athletes. So I will turn it over to him at this point.
All right, thank you, Alex. So we're going to be talking tonight, like Alex said, about abdominal pelvic trauma. So our objectives, we need to discuss the clinical features, how these present, talk through the most common injuries, know how to initiate the management of the injuries, because typically definitive care for these injuries are going to be at the hospital, in the emergency department, etc. And then discuss return to play for these sorts of injuries. So thankfully, intra-abdominal injuries are relatively rare in sport. Most of the time it's related to blunt trauma. So, football, hockey, ski jumping, cycling, you wreck, hit your handlebars, gymnastics, hit the beam, something along those lines. Very rarely in sports there's penetrating intra-abdominal injuries, such as a javelin mishap, high impact ski accidents, or archery sorts of things. But we're going to focus on the blunt trauma aspect of things. So why are we discussing this? So number one, these injuries have potential to be catastrophic, namely related to the potential for hemorrhagic shock and bleeding out into the abdomen. In addition to this, these can be really difficult to identify because sometimes your exam can be, really benign initially. The literature reports up to 50% of folks with significant intra-abdominal injury in sport have no red flags on their initial exam. 20% with blood in their abdomen have an unremarkable initial exam as well. So you need to maintain a high index of suspicion and know some subtleties related to picking these injuries up. So first of all, we need to know where things are within the abdomen, and remembering that organs can occupy more than one quadrant. But in general, abdomen, when we think about injuries, break it into four quadrants. Right upper quadrant is where your most of your liver lives, gallbladder, right kidney. You can have some small intestine, large intestine, and part of the pancreas there. Left upper quadrant, intestine again, stomach, spleen, left kidney, part of the pancreas. Right lower, again, intestine. Right ovary, part of the bladder, right ureter, part of the uterus, and then left lower, similar, but the things on the left side. So left ureter, left ovary, small intestine, part of the bladder, all of those sorts of things. So just brief reminder of where things are in the abdomen. There's really not much information out there on sports-related injuries to the stomach, gallbladder, ovaries, uterus, ureters, or aorta. And therefore, thankfully, those are rare, but those are not going to be the main focus of tonight's talk. We're going to talk namely about the more common intra-abdominal pathology that we find. So what is injured? The spleen is the most commonly injured intra-abdominal organ, greater than 25% of cases. Liver is next, but liver results in the most number of deaths related to intra-abdominal injuries, related to bleeding out from liver injuries. Then again, kidney, intestinal injury, and bladder rupture kind of make up the rest of the more common intra-abdominal types of injuries. We're also going to mention a few things about tonight about pancreas, rectus sheath hematoma, and some testicular trauma. So how does it happen? Again, typically blunt trauma. This was an event that I covered, which is part of the US ski and snowboard training camp, and this is in Saas-Fee, Switzerland. But on the half pipe, you can imagine someone falling down on the edge of the pipe onto their abdomen, for example. This is Nitro Circus, which is kind of acrobatic motorcycle stunts, for example. Can have handlebar injuries, wrecking into things. There's your typical just blunt trauma from anything from wrestling to football to hockey, etc. Can cause these as well. So, history and exam, as we mentioned initially, the signs and symptoms might be subtle up front and have a really benign exam, and they might not be as subtle. They could be in hemorrhagic shock. So, the majority of the time, they are not in shock initially. And so you need to maintain your high index of suspicion. And like I mentioned before, but this is again something to reiterate, is that initially there might be no red flags, and we'll discuss some red flags here shortly. But initial exam again may be significantly benign in these situations. History red flags, a few things. So nausea and vomiting, especially if it develops over time or if it's repeated. I don't get too fired up if there's one episode of vomiting, something along those lines, but if it's significantly repetitive, it develops over the next several hours, for example. Hematuria, especially gross hematuria, makes me worry about kidney injuries, bladder ruptures, etc. One of the kind of test question exam sorts of things could be the Kear's sign, which is pain radiating up to the shoulder related to free intraperitoneal air irritating the diaphragm, so you can get that referred pain up into the shoulder. And then, namely for hollow viscous injuries, so like a traumatic intestinal perforation, these are more likely to be some delayed presentations where you can have signs of bacterial or chemical peritonitis from this. So developing fevers, pain worsening over time, so multiple hours to days after the injury, and then developing peritonitis symptoms. So a classic example is, oh, I was driving somewhere and my abdomen hurts so bad every time we hit a bump in the road. As far as exam, one of the things in athletic population we have to remember is that typically decreased blood pressure is a late sign, in that typically well-conditioned athletes can maintain their blood pressures until a significant amount of blood loss has occurred. So you have to be more attentive to things like relative tachycardia. So a well-conditioned athlete whose resting pulse is 40, if their pulse is 80, that would be considered a relative tachycardia and maybe an early sign of things. And then the quote unquote thready pulse, where the pulse, when you're feeling it, it doesn't feel as strong as you would anticipate due to decreased pulse volume throughout there. And then again, red flag is peritonitis on exam. So classic things would be like the bumps in the road, like we talked about. One of the more common things that I kind of see clinically related to that is someone who doesn't want to lay down flat on their back to let you examine their abdomen because it hurts so bad when they're trying to lay back like that. Um, you discuss other signs would be rebound tenderness, so significant pain when after palpating, when you release the palpation, and then guarding, which is when people are flexing their abdominal musculature when you try to examine to prevent you from kind of pushing or irritating the peritoneum. So management just kind of globally when we're talking about intra-abdominal injuries, again, the primary goal in the sideline is not necessarily identifying the specific pathology, like saying, oh, this is a liver laceration versus liver hematoma versus um, kidney versus spleen. It's namely identifying signs and symptoms that prompt you to get them to the place where these things can be promptly evaluated in the most efficient manner. So identifying signs and symptoms of pathology needing further evaluation and management. You also need to be prepared to initiate some initial management strategies, which we'll discuss, and then know how to disposition these folks appropriately. So just kind of globally, that's where things go. And we're going to talk about these specific pathologies kind of individually. Management just kind of globally, again, it can be very wide ranging depending on what the problem is, anything from fluids to blood transfusions to antibiotics, if it's a hollow viscous injury, surgical, IR embolizations, and hopefully just observation, serial exams, etc. is the best case scenario. Always talk about imaging in these on the front of things. So in diagnosis of intra-abdominal pathology, one of the things that is typically not the standard is plain films or x-rays. Really, the only thing you may be able to pick up on plain film would be some air under the diaphragm, and this would namely be if there's a hollow viscous injury. Again, so you have a perforated your intestine and some of the gas is leaked out into the peritoneum. You may see a shadow where the air is accumulated under the diaphragm. Otherwise, x-rays, you may be able to see some, bony pathology when we start talking about associated injuries that can occur with these, such as rib fractures or pelvic fractures with this. Ultrasound related to these injuries. So I wanted to briefly bring up the FAST exam. So focused assessment with sonography and trauma. So the one thing we have to remember when we talk about FAST exam in sports medicine is that the FAST exam was developed for the purpose of determining who should go straight to the operating room and not get a CT scan first. So it wasn't developed in order to be, a sideline screening tool or something along those lines, but we've tried to adapt it somewhat to be able to at least do some screening related to it. So wanted to bring this up briefly. So it's a can be used as a screening tool for looking for blood either around the heart or in the abdomen. Most literature says that you need 200 milliliters or more of blood in the abdomen to see abnormalities. There's some controversy on the exact amount. Some people will argue lower or higher, but 200 is the number quoted most often in the literature. Again, it was developed and utilized like in trauma bays in the emergency department for folks who have unstable vital signs, a normal exam. Is it safest to take them to the operating room for a surgery, an X-lap to see what's going on? Or if they're hemodynamically stable, then they typically go to the CT scanner to get an image of things first. One place where this could potentially be helpful on the sideline would be, in that 20% of those with hemoperitoneum that may have the benign initial exam. You could do this exam, and if you see concerning findings or an abnormal or a positive fast exam, it may be you may be able to see some of these things on the exam prior to them getting real symptomatic. So that population is one where there's potential for this being helpful on the sideline. This isn't a lecture about how to do the FAST exam, but real briefly, there's 4 views related to it. Right upper quadrant or Morrison's pouch. So you have kidney, liver, and then you're looking for blood accumulating between those two. So the hypoechoic black area here is blood. And this is the area where they say, they kind of quote that 200 milliliter number of being able to see this area of free fluid on the FAST exam in the right upper quadrant. Left upper quadrant, you're looking for, again, the same thing, the hypoechoic area concerning for blood, either around the spleen, can be between the spleen and the kidney, in the splenorenal space, but looking for abnormal hypoechoic fluid or blood around that area. Then you also take views, look for heart and bladder. So you can do a subxiphoid view of the heart, looking for, again, free fluid around the heart. That should not be there. And then in the bladder, so this is bladder, and then there's you can see the bladder wall here, and then free fluid kind of outside of the bladder, which could be a sign of this. So especially with the bladder views, you have to be a little bit careful because people can have some physiologic fluid in this area. So there's some nuance related to doing these exams, but wanted to at least bring that up as a potential screening tool for things. CT scan is the imaging modality of choice in hemodynamically stable patients for most intra-abdominal injuries. It's more sensitive. It allows for grading of injuries, liver, spleen lacerations, etc. And you can also typically get good read on if there's other injuries associated with it, such as bony pathology, rib fractures associated with liver or spleen injuries, pelvic fractures associated with bladder ruptures, and those sorts of items. So, here's just an example of an abnormal CT scans kicked in the left flank during a football game. And again, this is the spleen here, and you can see there's evidence of bleeding where it shouldn't be. So as far as sideline management of any of these injuries, again, like we discussed briefly earlier, we might not know exactly what the injury is, but if we have suspicion for an acute pathology in the abdomen, biggest concern right away would be, are they bleeding where they shouldn't? On the sideline, you want to keep them lying flat if you can. You need to activate your emergency action plan, get EMS there, get them to the hospital. If you can do things like check vital signs and provide some IV fluids if you have that capability at your facility or where you're taking care of these people on the sidelines. So the biggest part of this management is identifying again when these injuries are highly likely and getting them to the appropriate place so we can do the imaging such as CT scan, labs, etc. Because I know I don't have a CT scanner in my training room, so uh, I'm guessing most people don't. So got to get them to the emergency department. So we'll start talking about some specific pathology now. Again, the spleen is the most commonly injured intra-abdominal organ in sport, typically related to direct trauma. Sudden decel injuries can injure the spleen as well. So, oops, I ran into something when I was going really fast. And then displaced rib fractures as well can cause this. With the spleen especially, you have to remember infectious mononucleosis as a potential cause. So acute pathology or spontaneous rupture needs to be in the differential for people who have abdominal pain and symptoms of mono or have had mono in the recent past. So again, you know, a great learning topic is always what are the most up-to-date infectious mononucleosis recommendations in sports. So make sure you take time to review those sorts of things as well. So if you suspect a splenic rupture, you know, what do we do in the emergency department? Typically, you'll obtain labs, including um, serial hemoglobin or hematocrit, looking for changes, coagulation studies. Typically, if you're concerned for bleeding, type and cross match for having blood ready in case it's needed. Imaging. CT with IV contrast is again the standard. Ultrasound may also be utilized in the emergency department as a screening tool and as part of like a fast exam, for example. Typically, splenic ruptures are admitted to the hospital for serial exams, serial lab checks, vital sign monitoring. When they get admitted, one of the things to remember is that they should be at a place where if they have changes in their status, so if they're hemodynamically stable, if that changes, do they have access to prompt re-imaging or interventions such as interventional radiology or surgeons? Typically, splenic ruptures or bleeds are treated non-operatively if the patient is hemodynamically stable. More common than surgery or a splenectomy is using interventional radiology for an embolization of whatever's bleeding at that time. So splenectomy may be indicated if someone is hemodynamically unstable. Return to play for all of the intra-abdominal stuff as we'll kind of go through all of the different pathologies. There is no consensus return to play guidelines on really any of these things. So a lot of it is based off of some expert opinion, case series, etc. So in general, for splenic injuries, you need to allow the appropriate time for healing. So there's some general guidelines in this table, depending on grades of injuries, on approximate number of weeks, depending on grade of injury. So allow appropriate time to pass. They need to be symptom-free. If they had any procedures, those procedural wounds or scars or wounds need to be healed, and then they need to return to their baseline cardiopulmonary fitness. As far as return to play, so like the lower grade injuries, grade 1, 2, they're typically restricted from activity from all activity for approximately 2 weeks. Grade 1 can return to full activity by 6 weeks. So there's usually a graded ramp up period trying to get your cardiopulmonary fitness back before you're going out and risking repeat trauma to the area. More along the line of 2 to 3 months for grade 2. For the higher grade injuries, usually you need to have a little bit longer time of just doing your activities of daily living before getting back into everything. And then once their symptoms have improved, then you can start to do a kind of a graded return to exercise type of program with them. If someone does end up needing a splenectomy, one of the things to remember is don't forget your vaccinations that are needed in that setting, such as pneumococcus, meningococcal, and H flu. So always keep that in mind. For the spleen, and this comes up occasionally in liver or renal injuries as well, and this is not the kind of consensus recommendation, but there have been instances in high level, meaning professional athletes, where they have chose to undergo a splenectomy to decrease the amount of time they need to be out, or they have gone to doing serial CT scans to monitor healing to see if they can get back any sooner. So obviously there's significant risks with doing a surgery that may not be necessarily indicated, everything from surgical complications to infectious concerns for surgery. And then on serial CT scans, especially the radiation risk associated to things. So that is not a standard recommendation to do repeat CT imaging for any of these things for return to play decisions. But I can't say that it is not ever done, because it is done on occasion in some athletes. Typically, the only reason to do repeat imaging or CT scans in these injuries are if there's a change in hemodynamic status. So someone was initially hemodynamically stable, and then several hours later, they all of a sudden become hemodynamically unstable. You may need to repeat imaging to see what has changed in the meantime. As far as liver goes, very similar mechanism as the spleen, just on the other side. You notice lots of similarities between kind of the workups and plans for the different organs. One difference in laboratory analysis for liver injuries is checking your liver function testing, because one of the return to play guidelines is that your liver function tests need to return to normal prior to returning to play. Typically, again, CT scan is the imaging modality of choice. Ultrasound may be used as a adjunct to this. Graded 1 through 6, 6 being the most severe. Typically, these get admitted for at least observation, even if hemodynamically stable. Serial exams, H&H, vital sign monitoring. Again, same caveat with if they are admitted, they should be somewhere where you can get re-imaging or have the specialists on call who can intervene if needed. Management is typically dependent on hemodynamic stability. The higher grades means higher likelihood of a procedure. More common is an IR embolization procedure as opposed to surgery, but surgery is necessary sometimes in the highest grades of injuries or in persistent hemodynamic instability. Or if they're in a facility where hemodynamically unstable, you don't have IR capability, but you do have surgical capabilities. Return to play for liver injuries, again, no consensus guidelines. Typically, these are at least 4 months, regardless of the severity of injury. with being able to resume some progression, so higher levels of working out, if you will, but not at risk for repeat trauma at about 3 months. The highest grade injuries can take a good 6 months. You also need normalization of your liver enzymes, return to baseline cardiopulmonary fitness, and then clearance from consultants if any of them were involved, such as surgeons. Again, repeat imaging not recommended for return to play, but again, that does happen on occasion in some professional athlete situations. Renal injuries, kidney injuries, again, mechanism, blunt trauma to the abdomen, back, or flank. A big red flag for renal injuries is gross hematuria. So that's always a question you need to ask folks um, related to intra-abdominal trauma assessments. Labs again, you notice the top line is very similar for all of them. Again, we're monitoring for signs of blood loss, being ready to give blood if too much is lost. For kidneys, also, you typically will check electrolytes, including creatinine, and obtain a urinalysis, looking for not only gross hematuria, but microscopic hematuria, because that microscopic component is needs to be resolved prior to return to play. CT, again, the standard for evaluation, graded 1 to 5, 5 being the worst. Thankfully, most of the sports-related injuries are grades 1 or 2. Again, most of the time, people are admitted for the same things as the other injuries we've talked about. So the serial exams, serial H&Hs, vital sign monitoring, location to be able to intervene if we need to be. And then you'll notice again, management's dependent on hemodynamics stability. Typically, again, you if capable, IR embolization of whatever is bleeding is preferable over surgery, unless that's not capable at that time. If you have a really low grade, so like a grade 1, there is potential. This is one scenario where there's potential for someone to be discharged from the emergency department in the appropriate setting, meaning that you have prompt access to be able to return, you have really close follow-up, etc. But in general, admitting for observation is a standard there. Return to play. For these, you need resolution of your symptoms, healing of any procedural sites, resolution of hematuria, and this is where it includes the microscopic hematuria. Most severe grades heal within approximately 8 weeks, but the microhematuria, even for the lower grade injuries, can typically last for up to 6 weeks related to them. Intestinal injuries, so hollow viscous injuries or traumatic bowel perforations, thankfully are relatively rare, but these can be very difficult to pick up because these typically have a more delayed presentation because typically, you're not having a huge significant amount of blood loss, etc. Symptoms may not develop until you start to develop a chemical peritonitis from the intra-abdominal contents that are supposed to be in your intestine, getting into the peritoneum and causing irritation, infection, etc. So for that reason, diagnosis is often delayed, even up to a few days, which increases people's risk for developing intra-abdominal abscesses or sepsis related to having infection. Again, the potential for the benign presentation is the biggest concern here. So especially if someone has a blunt abdominal trauma over the next, 1 to 3 days, they start developing worsening pain, they develop fever, they develop peritoneal signs. Those are red flags that we need to get this evaluated promptly. So if they come in to get evaluated for that, you typically would check, your CBCs, your metabolic panels, CBC looking for not only blood loss, but for signs of infection, potentially a lactic acid if you're concerned for sepsis. CT with IV contrast is once again your standard for imaging. Treatment includes resuscitation, typically anything you would do for someone who has who is septic or has a systemic infection, including IV fluid resuscitation, IV antibiotics, and these injuries have a very high likelihood of surgical intervention to not only repair the hollow viscous injury, but potential need for like washouts of infections as well. Typically, people are in the hospital for IV antibiotics and transition to outpatient antibiotics for a period of time afterwards. And then return to play in these situations are typically dependent on the surgeon. So obviously they have to feel back to normal, but then typically they can progress some sort of activity once their wounds are healed. How quickly that surgeons are comfortable with progression is dependent on a lot of things related to having had to open their abdomen. So 6 weeks is typically when you can start to do something, but typically significantly longer for to be fully healed up and be able to go. Because of delayed presentations, there's also high risk of these for some post-operative complications, such as developing abscesses that may need another procedure, such as drainage or even prolonged antibiotics related to it. So uh, next organ is the pancreas. So thankfully, this is rare in sports, but we have to bring it up because it has very high morbidity and mortality associated with it, especially if diagnosis is delayed more than 24 hours. How does this happen? You get hit on the front side of your abdomen, your pancreas gets smashed back against your spine. One of the historical features of this is when you read about traumatic pancreatic injuries, typically, oh, ow, I got hit there. It hurts. Hey, it's getting better over the first few hours. And then over the next several hours, it worsens. So typically when we talk about, worsening symptoms, the hollow viscous injuries typically take a little bit longer than 6 to 8 hours for that chemical peritonitis to kind of develop. With pancreatic injuries, it's typically over kind of that next 6 to 8 hours after the injury where that happens. So hurts, gets better, starts hurting again really bad afterwards, kind of in the epigastric area. Lab workup, again, CBC, CMP, but then in addition of your pancreatic markers, so amylase and lipase. CT with IV contrast is again your standard. However, there's also a need for additional imaging, whether it be with MR or ERCPs to evaluate the pancreatic duct. That can be really important because if there is actual injury to the duct itself, they are likely to need some sort of procedure to help the duct get better. So whether that be stenting versus surgical intervention, if the duct is involved, they typically need a procedure. They're admitted for observation for typically bowel rest. These are typically pretty painful, and because they're on bowel rest, they typically need IV fluids and symptom control as well with pain medications. Again, no consensus return to play guidelines, but in general, symptoms have to be better, procedural wounds healed, clearance from consultants, and that would typically mean return of laboratory pancreatic labs, so amylase lipase back to normal, and then again, returning to your baseline fitness levels. Bladder rupture, typically a direct trauma to the pelvis region. It's typically associated with other injuries, namely pelvic fractures, especially in adults. Children and adolescents are at higher risk for just having an isolated bladder rupture than adults because because of the bony pelvis isn't as developed. So in adults, especially if you suspect this, also be thinking, what other bony pelvic injuries could we have? Here again, your hematuria is concerning. Gross blood at the meatus, peritonitis, can't void urine, and the presence of a pelvic fracture should increase your suspicion for looking into this and making sure that uh, bladder rupture is not present. Um, Imaging wise, if you have concern for this, there's usually multiple studies that you're going to need because of the associated risk of other injuries. So you may need X-ray looking for bony pathology, potential for ultrasound, fast exam, etc. CT with IV contrast, and then cystography as well, especially if you're concerned for um, um, any if you have any urethral type of injuries associated with it. These are typically surgically treated. There are some cases dependent on a very specific type of bladder rupture where they can potentially be treated non-operatively, but in general, they're treated surgically. No standard return to play again, but you need a multidisciplinary approach. Usually there's a surgical team that would need clearance. There's typically other injuries such as your bony injuries that would also need to be cleared. Wounds would need to be healed up, and you'd need to have return of your cardiopulmonary fitness associated with it. Not inside the abdomen, but rectus sheath hematoma is something that can happen with blunt trauma. Um, the so you're hit on the abdominal wall, typically caused by the rupture of epigastric vein or artery. People can have focal tenderness over an area of the abdominal musculature, depending on how much soft tissue they have over the musculature. You may be able to feel or see an abdominal wall mass in that area. Labs again looking for bleeding, serial H&Hs, coag studies. CT imaging with IV contrast is again the standard for this. You can see these on ultrasound, but CT is typically again the modality of choice. One reason is so that you can look for active extravasation or continued bleeding within the area. Management of these are highly dependent on size and their hemodynamic status. A lot of these, if they're smaller, they may just need, hey, lay there, put some ice on it, and let's observe you, make sure it's not continuing to bleed or getting bigger, up to surgical management. So surgical intervention is typically reserved more for if the hematoma is quite large and compromising like skin tissue because of so much pressure on the area from the bleeding underneath. Otherwise, if there is continued active bleeding, interventional radiology, embolization of the bleeding vessel is typically the modality of choice if there's going to be a procedure. A hematoma greater than 7 centimeters with active bleeding is one indication, at least in the literature, for doing a procedure to get the bleeding to stop. Return to play, basically, once the pain is resolved and the wounds have healed. And then the same thing for getting back to your baseline fitness as well. So. And then wanted to mention briefly testicular trauma as well. Just real briefly on this. Remember that blunt trauma can cause testicular rupture or torsion. This would typically cause immediate severe pain. Nausea, vomiting might be present with this. The imaging modality of choice for this is Doppler ultrasound, and then at a location where emergent urologic surgical consultation is available, because surgical intervention, if these happen, is typically necessary. Return to play, again, there's no consensus once again, but wounds need to be healed. Whoever intervenes, urological surgery would need to clear them, and they need to get back to their baseline fitness. If an orchiectomy is necessary, one thing to remember is that prior to return to play, there needs to be some counseling on using protective equipment, fertility considerations. There may be some need for a discussion on a few other things related to this type of injury than the others. So for future needs. So that is what I had to share with you guys on that topic. I know that there was a lot of information there, but there's also a fairly large lack of information on this topic um, as well. So let me know if you guys have any questions on this.
But I guess one thing that I think might be helpful is kind of in what tools do you have with you on the sideline to help with diagnosis of these problems, and in what scenarios are you considering re-examination, and how long are you waiting to re-examine those patients?
Yeah, so the tools that I have on the sideline is kind of dependent on the setting that I'm in. At high level Division I athletics, I have for diagnostic tools, I do have like a portable ultrasound machine that I carry with me. We have um, intervention wise, we have IV fluid capabilities in the training room, on the sidelines, etc. When I'm covering high school football or something along those lines, I typically historically have not had those things. I've had, ability to potentially check vital signs and do an examination on them. As far as, how often are we re-examining folks? Um, Again, it kind of depends on the setting of things. It can be difficult to do serial examinations depending on which setting you're in. If you are, at a high school and it's the end of the game, being able to examine them, every hour for 3 or 4 hours can be difficult, just based off the setting there. But if it's in a collegiate training room or something along those lines where you have multiple resources available, or multiple physicians, athletic trainers, etc., to help with some of those things, that would be acceptable. Typically, I'll examine people initially. I'll give them, 10 minutes or so to kind of let the initial stress of things calm down. I'll be talking to them during that time. I'll be checking their vital signs during that time. Um, and if there's any concern initially, then typically we start down the treatment pathway of things. If I have a lower suspicion, but I want to re-examine them, I would typically want to do that at least over an hour-long period initially. If people are significantly improved during that kind of, period of things, then I would be much more reassured, um, with the caveats of making sure that they have someone that and the capabilities of being able to get somewhere if need be. So if I'm at a high school game, I'm talking to the parents, talking to the coaches who are going home with them on the buses. These are things to look out for. If they start vomiting, if they start feeling dizzy, lightheaded, like they're going to pass out, if their symptoms are getting a lot worse, you got to call 911 or get to the emergency department right away. And then for, hollow viscous type injuries, those can be reexaminations over the next, day or two even. So when you're seeing these folks and talking with them and sending them home, even if you think it's benign, you need to talk to people about what those red flags are. So, hey, tomorrow, if you're feeling worse, if you're developing a fever, if you're feeling a lot of pain when you're driving home from work, can't lay flat comfortably, these are all things that we need to know about right away. So that educational component is a part of it as well for sending people home.
Perfect. Thank you. Any questions from anybody else? All right. Well, I guess that will conclude our lecture series tonight. Thank you, Dr. Mathiasen, for taking time to give us this lecture. We greatly appreciate it.
You're welcome.